بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. ما زلنا مكملين European Society of Vascular Surgery guidelines for the management of descending thoracic aorta diseases, and we are still talking about the components of the acute aortic syndrome, and today we'll talk about blunt traumatic thoracic aortic injury. Actually, blunt traumatic thoracic aortic injury, or TAI, most often occur after a sudden deceleration as a result of head-on or side impact collisions, usually in high-speed motor vehicle accidents or falls from great heights. The classic site of TAI is at the aortic isthmus in about 55 to 90% of patients admitted to the hospital alive. And after the traumatic brain injury, TAI is the second most common cause of death in blunt trauma patients. The morbidity and mortality of this injury are high, causing sudden death in about 80 to 90% of cases. The damage incurred in the traumatic aortic injury or thoracic aortic injury can be partial or even circumferential. With more accurate diagnostic tools, the term minimal aortic injury, which implies the presence of a small intimal flap with minimal to no peri-aortic hematoma, has been introduced to describe a lesion that carries a low risk for rupture. Classification scheme for the traumatic aortic injury, the thoracic aortic injury, has been proposed actually either by the Society of Vascular Surgery classification into type 1, which is intimal tear, type 2 intramural hematoma, or a type 3 presence of pseudoaneurysm, or a type 4 which is complete rupture, or the other classification system, which is the Harbor View classification system into a minimal grade or a moderate grade of thoracic aortic injury or a severe. So in the minimal grade, there is no external contour abnormality, and an intimal tear and or a thrombus is less than 10 millimeter. Or a moderate, which is the external contour has an abnormality, or there is an intimal tear or a thrombus more than 10 millimeter, or the severe form of thoracic aortic injury is the active extravasation. About 2 to 8% of patients with an initially unrecognized thoracic aortic injury may develop a chronic post-traumatic pseudoaneurysm later on. And up to 85% of these patients underwent surgical repair, and 1/3 of the remaining patients actually died from their untreated lesions within 20 years of the initial trauma. So if the patient had a severe form of injury, as we said, the head-on or a side collisions or a fall from great height, actually a high index of suspicion is needed to prevent such a delayed complication of a pseudoaneurysm or a chronic pseudoaneurysm, which may be fatal for these patients. Clinical presentation of the thoracic aortic injury ranges from non-specific symptoms to thoracic or interscapular pain, signs of chest wall injury, pseudocoarctation syndrome, presence of a systolic murmur, paraplegia also can be present. The risk assessment for thoracic aortic injury begins again with a high index of suspicion based on the mechanism of injury. Abdominal injury, thoracic injury, hypotension, and lack of restraint motor vehicle accidents have been identified as a clinical predictors of thoracic aortic injury. The greater the blunt trauma force, the higher the index of suspicion of TAI should be. And when we have this high index of suspicion, we need to do a CT angiography for this patient to exclude or to confirm the presence of this type of injury. Initial plain X-ray have a significant false negative rates in patients with thoracic aortic injury, but if there is a sign in the chest X-ray, it could be a widened mediastinum. CT angiography is quick and reproducible with a near of 100% sensitivity and specificity in identifying the thoracic aortic injury, and in addition, the CT angiography is ideal for evaluating non-arterial trauma also, such as the brain. We have mentioned it is the first cause of death in blunt trauma, or spinal, pelvic, splenic, liver, and kidney damage in patients with multiple injuries. So what is the treatment modality of choice? It is actually the CT angio, which can diagnose this pathology with a very high sensitivity and specificity, and it can also provide a management plan for endovascular intervention. CT angiography findings associated with the thoracic aortic injury include a mediastinal hematoma, hemothorax, pseudoaneurysm formation, variation of aortic contour, and the presence of intimal flap and the presence of thrombus inside the aorta. So we can classify these injuries according to both classifications, either the SVS classification or the Harbor View classification. Digital subtraction angiography now has a very limited role in the thoracic aortic injury. With the increasing use of TVAR, actually IVUS has been advocated as having an important role in evaluation of selected patients with suspected thoracic aortic injury. Most patients who undergo TVAR for thoracic aortic injury are young. These patients have a healthy and elastic aortic wall with increased aortic pulsatile compliance, and these patients are hypotensive due to the mode of injury in the car accident or in the crash accident. So the aortic diameter in these patients actually may vary by 10% and up to 18% between systole and diastole. Due to presence of two items, these patients are young with an elastic aortic wall, and the second thing, these patients are hypotensive and are not resuscitated well yet. So the sizing of the TVAR operations or in the CT angiography, it may actually be of variable sizes than the intraoperative IVUS, which permit a dynamic real-time evaluation of the aortic diameter during the cardiac cycle and intraoperatively when the patient is adequately resuscitated. So IVUS is the modality of choice for treatment of these patients as regard the sizing of the TVAR stents. Furthermore, IVUS can easily detect the origin of side branches, allowing less use of contrast with the digital subtraction angiography, and once the stent graft is deployed, IVUS can use to evaluate the adequate expansion of the stent, excluding enfolding complications. And also we can use the transesophageal echo, which can be used intraoperatively to monitor the myocardial function and fluid management of this patient. The appropriate timing of any operation in patients with thoracic aortic injury remains controversial. And why this controversy? Due to presence or absence of other life-threatening injuries. So if the patient has another life-threatening injury, as an intracranial bleeding, an extracranial hematoma or something, an extradural hematoma or something, and the aortic injury is moderate, so we can manage the cranial trauma first, then to do the aortic injury. But if the traumatic aortic injury is severe, so this is the life-threatening lesion that has to be treated first. About 9% of patients reaching the hospital hemodynamically stable progress to free rupture. The majority of these ruptures occurs within 24 hours. For this reason, immediate treatment of the thoracic aortic injury was considered the standard of care for many years, but more recent studies have shown that a reduction in paralysis and mortality with delayed treatment. So this is the controversy present in management of thoracic aortic injury. In 2008, study concluded that in patients with thoracic aortic injury associated with major injuries, they are more likely to benefit from delayed intervention for this thoracic aortic injury. So this conclusion is consistent with an extensive review of the literature, studied more than 7,000 patients, which did not show a significant difference in mortality between early, within 24 hours, and delayed after 24 hours repair of the thoracic aortic injury, suggesting that repair can be delayed if other extensive injuries require stabilization first and after an adequate resuscitation of the patient. So the Society of Vascular Surgery suggests urgent repair within 24 hours, pairing other serious concomitant non-aortic injuries, or repair immediately after other injuries have been treated but prior to hospital discharge. And patients with a 15 mm or a larger arch hematoma were significantly more likely to die from the thoracic aortic injury than those with a smaller hematoma. By contrast, a minimal aortic injury that presents with an intimal tear and occur in 10% of patients with thoracic aortic injury may be managed expectantly with serial imaging for surveillance. So again, it depends on the degree of the aortic injury and the concomitant injuries during this crash or accident. What about the open repair? Open repair for the thoracic aortic injury at the classic isthmus location requires exposure of the thoracic aorta from the left fourth space thoracotomy with a single right lung ventilation to improve the surgical exposure. And this modality in such a patient who has another form of injuries is actually increasing the morbidity and mortality of such intervention. The aorta is clamped at the origin of the left subclavian artery and distal to the vessel injury. Various methods of distal aortic perfusion have been used to protect the spinal cord as a passive perfusion, which is an early technique used for a distal perfusion of the aorta, but meta-analysis have found that active perfusion with partial cardiopulmonary bypass is better than the passive perfusion, to put a shunt or something inside the aorta and to allow a passive distal perfusion rather than an active distal perfusion with the cardiopulmonary bypass machine. Optimal perioperative patient management with a skilled trauma team is mandatory to establish the correct timing and treatment priorities according to the patient's multiple injuries. Aggressive fluid administration that may exacerbate the bleeding or can cause coagulopathy and rupture should be avoided. So the mean arterial pressure should not exceed an 80 mm mercury. Presence of hypotension with a systolic blood pressure less than 90 mm mercury and the presence of a periaortic hematoma of a size larger than 15 mm were found to be an independent risk factors for early mortality in patients with thoracic aortic injury, and in patients suffering severe brain injury with elevated intracranial pressure and hemorrhage or significant lung injury. Delayed repair of the thoracic aortic injury is preferable to avoid further brain or respiratory deterioration. What about the endovascular repair? The first TVAR procedure for a post-traumatic aortic pseudoaneurysm was performed actually in 1987 by Nikolai Volodov in Ukraine. Since then, the TVAR has become the first choice treatment for this type of injury. Compared to the open repair, TVAR showed a significant reduced mortality, 9.7% versus 27.7%, and a trend toward reduced paralysis also of 0.5% versus 2.9% for the open repair. So open repair of the thoracic aortic injury was associated with a reduced stroke rate 0.4 versus 2.3%. So the open repair is superior than the TVAR only in the stroke rate, but the mortality is less in the TVAR population by nearly 10%. Overall, the endoleak incidence was 5.2%, type 1 proximal in almost all cases, and there was a 1% migration rate in this cohort study. Stent collapse occurred in 2.5% of cases with an associated mortality of 12.9%. So what is the cause of this endoleak? Again, it is inadequate sizing of the TEVAR stent in these hypotensive young patients with a major variability of the aortic diameter during the cardiac cycle, during systole and diastole. Most thoracic aortic injury occur in young patients who are more likely to have acute curvature of the aortic arch. This anatomical variant may limit the optimal apposition of the stent graft to the inner aortic curvature, and this may lead to a bird beaking and or an increased risk of endoleak and stent collapse. Excessive oversizing by more than 20% has been associated with an increased risk of device collapse. With respect to the preoperative CT angiography measurements, stent graft should be oversized by about 10%, and more aggressive oversizing may be applied in gravely hypotensive patients. And to overcome this point or this obstacle, adequate sizing should be done by the intravascular ultrasound instead of the CT angio done in an unstable hypotensive patient. Hypotension may lead to inadvertent undersizing of the stent graft and thus increasing the risk of stent migration and increasing the risk of endoleak, which is in most cases it is a type 1 proximal endoleak. Where possible, delayed TEVAR may allow a complete resuscitation, and in these cases a serial CT angio can provide a more reliable data regarding the actual aortic measurements for stent graft sizing, or we can use the IVUS after a full resuscitation of the patient intraoperatively. The necessity for left subclavian artery coverage during TEVAR for the thoracic aortic injury was reported in about 30% of cases in recent reviews. A separate consideration should be applied to chronic post-traumatic pseudoaneurysms, which have a different anatomical characters from the degenerative aneurysms in that they are typically localized calcified saccular lesions located just distal to the left subclavian, which is the most common site to be injured in the thoracic aortic injury, and this makes them attractive target for endovascular repair. The indications for late surgical intervention after aortic injury are not the same as those for other types of the descending thoracic aortic aneurysms, and we should have a follow-up strategies after the TEVAR for every patient with a traumatic thoracic aortic injury, and it deserves a special mention, and this is due to presence of a high percent of the complications, either migration or an endoleak or a stent collapse. So a combination of a multi-view chest X-ray may be done, a CT angiography and a serial MRA may be considered. What about the recommendations? The CT angiography should be performed for the detection of traumatic aortic injury, and in traumatic thoracic aortic injury, a transesophageal echo or an intravascular ultrasonography should be considered for intraoperative sizing and for the deployment of the stent grafts. Patients with free rupture of a blunt traumatic thoracic injury or a large periaortic hematoma more than or equal to 15 mm should undergo emergency repair, and in cases of blunt traumatic thoracic aortic injury without a large hematoma, delayed intervention should be considered to prioritize treatment of associated life-threatening injuries as an intracranial hemorrhage or an extradural bleeding. In patients with traumatic thoracic aortic injury and suitable anatomy, endovascular repair should be performed as the first option.